All right, we are going to spend 2 weeks on Chapter 12, which is on the cardiovascular system. So on the National Board exam, 20 to 25 questions, so that's 10% of the questions on the board exam, are on the cardiopulmonary system. So the way they divide up the sections of the exam, they have systems, and they have one that's non-system questions. So the cardiopulmonary system, respiratory system, neuromuscular system, musculoskeletal system, and non-systems. So the cardiovascular system is a big part of it, and you should know that. So we're going to spend a little more time reviewing some of the things that you probably learned in anatomy and physiology, and then we're going to talk about disorders of the heart. So there are 11 or 12 lectures in this 2 weeks. So pace yourself, spread them out. Some of them are only 10 or 12 minutes long. I tried to break it up into easily digestible chunks. But it's worth spending time on this chapter and really understanding what's going on, because a large portion of the board exam is on the cardiovascular system. So the circulatory system is composed of vessels, fluid, and a pump. The vessels are the veins and arteries, and the fluid is the blood, and the pump is the heart. The blood flows from the systemic to the pulmonary to the systemic circulation, and the blood is responsible for, the heart is responsible for doing all that. So it's the pump that really takes the red blood cells through their pathway. And there's a little graphic in the book on page 224 about the path of an erythrocyte in the circulation. I have it in the PowerPoint here somewhere, but it's kind of a neat way to look at it, and where, how does that one little red blood cell go through the pulmonary and the systemic circulation. So the heart, it's located in the mediastinum between the lungs. It's enclosed in the pericardial sac, which is that double-walled sac. We'll talk more about that a little bit later. The apex of the heart is the lowest part of the heart. It's the little pointy part at the end. It projects anteriorly into the left at the level of the fifth intercostal space and the left mid-clavicular line. The base is the top part, the flatter part. It's the upper border of the heart, and it lies approximately below the second rib at the level of the second intercostal space. So I'm not going to review all of the anatomy of the individual parts of the heart, except for the major chambers and everything, but you should still know all that stuff from anatomy and physiology. So if you have to break out your A&P book and review a little of that, that does not hurt. So the heart is in the pericardial sac. The pericardium is a double-walled connective tissue sac that surrounds the heart and its major vessels. So it's two parts: the parietal pericardium and the epicardium, which is also known as the visceral pericardium. And it's the serous layer. It's lubricating, basically, the motion of the heart. So that lubricating fluid within the pericardial cavity facilitates heart movements. So the middle layer of the heart is the myocardium. That's the thick contractile layer of muscle cells that forms the bulk of the heart wall. And then the inner part of the heart is the endocardium. That's the endothelial lining of the interior heart of the heart chambers and valves. So the myocardium, it's composed of those cardiac muscle cells that are electrically linked so they can contract rhythmically to forcefully pump the blood through the organs. The left ventricular wall is thicker because it's really sending blood out. It has to send it out farther. It has to go out through the systemic circulation. The inner layer of the heart, the endocardium, is it forms the layers of the chamber and the valves, and the valves are what assure that you have that one-way flow. So we'll talk about the consequences of valvular disorders later on. So we have two sets of valves. The atrioventricular valves that are between the atria and the ventricles, and the semilunar valves, which are basically between the ventricles and where the blood's going next, going out of the heart. So from the right ventricle, it's going out into the pulmonary circulation. From the left ventricle, it's going out into the systemic circulation. And the right side and left side of the heart is separated by the septum. Okay? So the major vessels of the heart, the aorta is the largest artery, and it's the central conduit from the heart to the body. So when the left ventricle pumps blood out of the heart, it goes into the aorta first. The superior vena cava, that is the return, the blood return from the head, neck, and arms into the right atrium. And the inferior vena cava returns venous blood from the lower body and the viscera to the right atrium. The pulmonary arteries carry deoxygenated blood from the right ventricle into the lungs, and the pulmonary veins carry oxygenated blood from the lungs into the left atrium. So the blood coming in through the venous system is deoxygenated. It comes into the right ventricle, goes through the atrioventricular valve into the right atrium into the right ventricle. It goes from the right ventricle into the pulmonary circulation where it gets oxygenated. Then it comes back into the left atrium. It goes from the left atrium into the left ventricle where it gets pumped out through the aorta into the systemic circulation. Okay, this is all not news to any of you, I'm sure. So, in order to initiate that cardiac contraction, those muscle fibers all have to work together. So the cardiac muscles, they have some unique characteristics between the muscle fibers so they can all work together. And then there's a conduction system that coordinates all of the information. And we'll find out when we talk about dysrhythmias and those type of disorders, if everything's not coordinated, stuff gets wacky and the heart doesn't work. So the heart's conduction system is super important to ensure that the atria contract together, followed shortly by the two ventricles contracting together. So the coordinated effort of the conduction system results in rhythmic and efficient filling and emptying of the atria and ventricles. And there has to be sufficient force to sustain the flow of blood throughout the body. So when you get, the interesting thing is when they're growing, they take cardiac stem cells and grow them in tissue culture. Once they get to a certain level of maturity, they start contracting together. So each one of the cardiac muscle cells can initiate an impulse, but normally the conduction pathway originates at the sinoatrial node. So the sinoatrial node is in the wall of the right atrium, and it's often called the pacemaker of the heart. The reason that we can transplant a heart from one person into another is because each heart has its own built-in pacemaker. If that didn't happen, we wouldn't be able to do heart transplants the way we can do now. So the sinoatrial node is the pacemaker of the heart, and it generates impulses at a basic rate, and this is called the sinus rhythm. The sinus rhythm is ordinarily about 70 beats per minute. It can be altered by the autonomic nervous system, which feeds into the sinoatrial node, or by circulating hormones such as epinephrine that the sympathetic nervous system can increase the level of epinephrine. But when you don't have that sympathetic activation, you have that normal basic rate, that normal sinus rhythm. So once the sinoatrial node sends the impulse, then the impulse spreads through the atrial conduction pathways, resulting in a contraction of both the atria. So then those impulses arrive at the AV node, or the atrioventricular node, which is located in the floor of the right atrium. So the right atrium is the place where the controllers of the conduction system are. So once the impulses get to the AV node, the AV node is the only connection between the atrial and the ventricular conduction systems. So there's a slight delay in conduction at the AV node to allow for the ventricles to fill, and then the impulses continue into the ventricle through the AV bundle, also known as the bundle of His. There's a right branch and a left branch, and the right and left ventricles are controlled by that. So the conduction of those impulses, those electrical impulses, produces a change in electrical activity that you can pick up with electrodes. And the electrodes, you can attach electrodes and you can get a drawing, basically, of the heart impulses. You can see when the atria contract, you get depolarization, and then you get depolarization of the ventricles. So we'll look at some EKG readings and see what they look like. So this is a basic electrocardiogram ECG wave, and they name each of the little lumps and bumps have names. So there's the P, the Q, the R, the S, and the T. So the P wave represents the depolarization of the atria. The QRS wave, so the Q is that little hyperpolarization, and then the R is the big depolarization, and the S is that other little hyperpolarization. So that QRS wave is the depolarization of the ventricles. And then the T wave, that little blurb at the end, is repolarization of the ventricles. So they have to be depolarized and then repolarized. So the atria depolarize, and that's the P wave. Then there's a little bit of a delay, and then you get depolarization of the ventricles, the QRS. And then you get repolarization, and that's represented by the T wave. So abnormal variations in this rhythm are known as arrhythmias or dysrhythmias, and they can indicate problems. So an ECG is one of the major diagnostic things that they use initially. So you can have problems like myocardial infarction, or systemic problems like electrolyte imbalances. Potassium imbalances can cause arrhythmias. So an EKG is kind of one of the first diagnostic tests that they do. And we'll talk more about diagnostic testing. So here's our little diagram showing the EKG. So the impulse is generated by the sinus node, travels through the atria to the AV node, down the bundle of His and those Purkinje fibers to the ventricular myocardium, and we get that characteristic electrical pattern. Okay, so the heart rate and the force of contraction are controlled by the cardiac control center in the brainstem. It's in the medulla oblongata. It controls the rate and the force of contraction. There are baroreceptors, so they're nerve receptors, mechanoreceptors, that detect changes in blood pressure. They're located in the aorta and in the internal carotid arteries. So those nerve pathways send messages to the medulla, so it can control the rate, the heart rate and the force of contraction. Sympathetic stimulation, so the sympathetic system is our fight or flight system. It's also known as the cardiac accelerator nerve, increases heart rate, tachycardia. So when we talk about heart rate, tachycardia is a fast heart rate, bradycardia is a slow heart rate. So sympathetic stimulation ramps you up. Parasympathetic stimulation calms you down. So the parasympathetic stimulation happens through cranial nerve 10, which is the vagus nerve, and that decreases heart rate. So there are lots of different sites in the nervous system that control the heart. So there are receptors in the heart, and they call them beta-androgenic receptors. And it's an important site of action for some of the cardiac drugs, namely beta blockers. So beta blockers fit into the receptors and they prevent normal sympathetic stimulation. So when you have a patient on beta blockers, their heart rate will not go up even if they're exercising. It will not go up past a certain rate, and that's what they use the beta blockers for. They want to block any increases in rate and force of contractions. If the heart has been damaged, they want to keep the heart rate low. So they use those beta blockers to do it. They prevent sympathetic stimulation. So when you have someone that's on beta blockers, you have to teach them to use their rate of perceived exertion to monitor their exercise rather than their pulse rate, because their pulse rate is going to stay pretty much the same on beta blockers. But there are other factors that increase heart rate. Increased thyroid hormones or epinephrine can increase heart rate. Elevated body temperatures, as from an infection like a fever, can elevate your heart rate. Increased environmental temperature, especially with high humidity. Exertion or exercise, we know that. Smoking elevates your heart rate. A stress response, pregnancy, because the heart has to work harder, and pain can elevate your heart rate. So all those things can cause an increase in heart rate. The coronary circulation, all of that, all of the myocardium, the muscle of the blood, requires a constant supply of oxygen and nutrients so it can contract efficiently and conduct those impulses. So the heart doesn't store any oxygen. So you have to have a really good circulatory system to supply oxygen to the myocardium. So there are, we'll talk about the individual coronary arteries. There are basically two major ones, the right and the left coronary arteries, that branch off the aorta immediately above the aortic valve. So as the blood is going out from the left ventricle into the systemic circulation, its first stop is the coronary artery. So the heart is sort of the most important customer. It's its own most important customer, if that makes any sense. So the left and right coronary arteries branch off the aorta, and then the left coronary artery divides into the left anterior descending and the left circumflex artery. So it divides into left and right, and then the left immediately divides into two parts. The right coronary artery goes along the right atrioventricular sulcus on the posterior surface of the heart, and it branches into the right marginal artery and the posterior interventricular artery. And then it descends into the posterior interventricular groove towards the apex of the heart, which is the point. And that comes to the terminal point of the left anterior descending artery. So the arteries pass over the surface of the heart in the little grooves in the heart, and it's really kind of helpful when they're doing bypasses, coronary artery bypass grafts. Those little grooves of the heart give them a good map on where to find things. So we'll talk about that a little bit later when we're talking about disorders. So a lot of small branches extend inward from the large branches to supply the myocardium and the endocardium with oxygen and nutrients. So the blood flow through the myocardium is greatest during diastole or relaxation, and it's reduced during systole or contraction, as the contracting muscle compresses the arteries. So if you get rapid or prolonged contractions, it can reduce the blood supply to the cardiac muscle cells. So that's pretty important, to know that during diastole, you get better blood flow. So those are the branches that I talked about. So there's not a lot of collateral circulation in the heart. You get anastomoses, which are direct connections between coronary arteries. So sometimes you can get a bypass if one artery, if the blood supply is sufficient, the blood can take different routes to get to the same place. It's kind of like a backup system. It's kind of nice, but that collateral circulation is limited. It can only bypass a certain amount. It's like, say the highway is closed and you have to take side roads. It can't handle the level of traffic that the highway can handle, if that makes sense. Okay, so the major coronary arteries have valves to help with the blood flow. So any interference with the blood flow is going to affect heart function. So generally, the right coronary artery supplies the right side of the heart and the inferior portion of the left ventricle, and the left artery supplies the left side of the heart. So I guess that's all I'm going to say about coronary arteries. We'll talk in a later lecture about coronary artery bypass graft, and that's the procedure that happens when a coronary artery is blocked.